Hello from San Diego. I'm Jason Jacobson from Westchester Medical Center, and I'll be the host for this episode of Heart Rhythm Society's The Lead, brought to you by the Digital Education Committee. We're live at HRS 2025. This episode, we will be discussing one of the late-breaking clinical trials just presented earlier today. Today is Saturday, April 26th. It's the computed tomography-guided ablation of ventricular tachycardia, the InEurHeart trial by Sasher and colleagues. Here with me are two experts in the field. I'm very fortunate to have them join me today. Natalia Trianova from Johns Hopkins University and Tim Dickfeld from the University of Maryland. Welcome to you both.
Thank you.
Same state.
Yeah, not too far apart, right? Thanks for joining me. I think this will be a great discussion. Tim, could you please summarize the paper for us?
Jason, thank you so much. As the paper was presented today, you don't have anything in print yet, and I think part of this is going to reflect on the discussion a little bit. So I'm going to try to look at my notes that I took and try to do this as well as I can.
Right.
As you mentioned, the study is called InEurHeart, and tongue-in-cheek, the "your" in InEurHeart is EUR, and reflecting that this was performed in 4 European countries: France, Germany, Austria, and Switzerland, and there were a total of 14 centers. Interesting to note that 11 of those centers had no prior experience with the technology, so that there is a mix of experienced and non-experienced centers. Enrolled were 113 patients, and as you mentioned, the main goal is comparison of conventional VT ablation versus CT-guided VT ablation. Inclusion criteria sounds pretty much like the Vanish-like patients, so people that had a de novo indication for VT ablation. A prior MI, patients had an ICD or were getting an ICD at the time of the procedure, and then they needed to have some kind of monomorphic ventricular tachycardia in the last 6 months. And this was either ATP for 3 times, or it was an ICD shock, or sustained monomorphic ventricular tachycardia under the ICD detection settings, or on a 12-lead EKG in patients that didn't have a prior ICD. Exclusion, mostly polymorphic VT and VF, and a creatinine clearance under 30, just to make sure that people can receive the CT, and New York Heart Association Class 4. What is the workflow? Easy for the conventional ablation group, because those folks just got ablated what we all do, put a catheter in and do our best. For the CT group, however, they got CT up front, and then the CT was analyzed in the Lyric Institute in Bordeaux. And then they developed a 3D model with potential targets. Part of it is certainly the old Michael Gannon paper from 2018 in JCE, where they looked at the different wall thinning within the ischemic substrate, and were postulating that thicker areas in the areas of wall thinning represent conducting channels. Then this CT was integrated, and people were ablated in the predefined target areas, the kind of channels within this topographic ischemic scar map. And only then, after the ablation was done, did people undergo an electrophysiological study and ventricular stimulation. If there was no inducible VT, this was it, the procedure was done. If people were still inducible, then the treating physicians mapped the VT, ablated it, as we all do. And the conventional arm we talked about, just standard. People were randomized 1-to-1, so we have 57 patients in the CT group, 56 patients in our conventional group. The population is in general well balanced, 65 years old, EF is about 35. The people were about 15 years post-MI, so pretty matured scar. There are only 10% of women in the study, so mostly male. And the group, the CT group, had slightly more cardiac arrest, 24 versus 13%. The procedure, pretty similar, or maybe slightly less general anesthesia than what we see in the United States, about 40%. They found 3 isthmi, anatomic isthmi to ablate in the conventional group as well as in the CT group. 90% use of contact force catheter for the ablation in both groups. The differences, however, are that in the CT group, people use much less multipolar mapping catheters, only 26% versus 91%, and I guess that goes along with the idea of the procedure. Interestingly is that the RF duration of the treatment with RF therapy was longer, numerically 44 versus 36 minutes in the ablation group guided by CT, so more in the CT group. In terms of safety, pretty similar, 2% versus 4%, so no big difference in safety signal. Now, the meat of the study was the outcome, and interesting was that the primary endpoint is procedure duration, and this was shorter in the CT group, 120 minutes versus 149, so 19% shorter, and the p-value was significant, 0.003. A couple of secondary endpoints. We have, for example, the absence of VT after 1 year was numerically higher, 76.8 versus 67, so about 10% difference, but this was not significant and favoring the CT group. And then we have absence of a combined endpoint, which is cardiovascular hospitalization, cardiovascular death or VT, that was also numerically higher in the CT group, so it was better, 59 versus 48%. And then importantly also in 2025, the costs were favoring the CT ablation group, 6,100 versus 5,400 euros, and this was pulled from the French patient group. So 646 euros less, about 10% in terms of cost. The imaging portion, by the way, was estimated to be about 1,250 euros. So that's kind of the main finding. To put this in a nutshell, procedural time down, statistically significant by 19%, non-significant decrease in VT recurrence with CT, and decrease in procedural costs of about 10%.
Great. Thanks, Tim. That was, you got a lot from watching the presentation today. Natalia, what do you think the limitations are of this study, and where does this take us next?
So I come from a mechanistic background, so I'm going to comment on what are we doing when we are ablating that way. So, the assumption here is that the wall thinning represents really the true scar, and the scar is transmural, fully transmural. And areas of intermediate thickness represent channels, so kind of scar border zone. And then we have the largest thickness, that is the normal zone. So in doing so, we assume activity that is fully transmural. So whatever we see on the endo is the same on the epi. It does not assume that there can be any type of activations that are going in the wall across these geometrically defined areas. So that to me is a significant limitation. They have tried to mitigate that by selecting patients that are only 15 years post MI, and that ensures that this is an old scar, and maybe we have less potential for having channels of conduction that go through the scar. But this still remains to me a big limitation. So watching this today, and also I read the paper that was submitted here. They were in the early stage of the clinical trial. They had only 38 patients at that time. And what was interesting to find there, to read in that paper, was that 50% of the patients that were ablated in using the wall thickness, they actually did not, they were acutely inducible after that. So here there was today at the trial, they didn't report acute inducibility after doing the CT-guided ablation. This is important because what was in that initial paper is they do the CT-guided ablation. If VT is still inducible, they continue ablating in the conventional methodology.
Right.
But that is reported as an outcome of the arm that is CT guided. So some of these patients might be entirely ablated based on the imaging. Others in the same arm, for which outcome is reported, might be ablated both a combination of CT and conventional.
Right.
in defining what are the ablation targets, as I said, the channel is defined, this intermediate thickness. There may be intermediate thicknesses in many places. Which of the channels are the active carrier, so to speak, of the reentrant activation that is being targeted is not clear. So it's interesting to see what is the lesion size and to compare with conventional ablation. Another interesting aspect is when there is a channel. In a channel, what are we ablating? Are we ablating sort of the midpoint in the channel? Are we ablating the exit or the entry? And in the original paper, they initially ablated in the middle of the channel, but then decided that that wasn't the best approach and moved the ablation to the exit or entry. I think it will be very interesting to see, do you have to ablate in the middle and then move it, or it is just one ablation? Or how is that? To me, that is an important component of what was done. So I think it is, to me, I believe in image, assisted ablation. Mm-hmm. I just don't know, that approach probably is not going to work well in earlier infarcts because of the reasons that I just specified. Another thing I have to mention is, this is an image-assisted ablation, but they, at the conclusion slide, they had a sentence that it is a digital twin assisted. That is not a digital twin. Digital twin is very well defined. We have documents now from the national academies. It is a dynamic entity. A picture of you is not the digital twin of you. Right. The digital twin represents how you function, how you respond to stimuli. And so I would say they should stick to the image-based, image-guided ablation.
Right, so digital twin takes into account kind of a virtual electrophysiology.
Virtual electrophysiology is the electrical functioning. Yeah. It's a functioning rather than just an image of structural remodeling, which this is.
Right. Tim, what do you think about, what they chose as their substrate, just being wall thinning? They also are able to do late iodine enhancement. There's also fatty metaplasia. All these different other imaging parameters have been utilized. Do you think we're missing a large part of what we could be targeting?
I think, Jason, this is a good point, right? So we started now nearly a quarter century back, and it's just for the listeners, some of our listeners may not have been around as long as maybe we have documented. Not Natalia, but you and I,
yes,
by the losing hair and the gray hair. How did this all start? 25 years ago, pulmonary vein ablation came in, suddenly anatomy became more important. That was around 2002, 2005, and then a few years later, imaging of the scar in the ventricle, and that's kind of how this whole field took off. I think we all have been striving to find this holy grail of imaging that we can only do it by imaging, and I think we also have to admit that over 2 decades later, we have to admit we have not found that holy grail. At the same token, I think this is an important incremental step. There are other things to make it better. Natalia mentioned many of them. You bring up other ones, right? Fatty replacement, delayed enhancement is going to be better. Now, I'm going to just make an argument in favor of that approach. It is very doable, and it is doable in many centers. Not everybody has the technical feasibilities that Natalia has or that you may have, that some of the high specialized centers have, but that is something that can be done in the majority of academic and non-academic community centers. And so that is where I think there is some value to that. We can make this better. There's no doubt. And I'm not. In 10 years we're going to have success rates that are better, partially based on our imaging. But if I put my practical hat on, I think it provides a reasonable approach. It shortens procedure times. You and I know how important it is when we talk to our administrators about getting resources. They are very interested and understand this concept of shorter procedure times. There was no safety signal that would be concerning, and the success rates were pretty good. Now, I think the paper is super important. What Natalia mentioned, we need to see how many of those CT ablated patients needed additional ablations, and I think the fact that the ablation time was longer points towards this fact that it might just have been additional ablations, and then it could be that there were actually more ablations done. But to the counterpoint, I'm going to say it still took less time. And that is still something that I think is meaningful, because we do know that ablation time matters in terms of complications. It matters for our administrators in terms of lab resources. So I think this is an important incremental step forward. We now have a couple of different companies helping getting image reconstruction into the lab. The process has gotten much, much easier. So I think all over I'm on the positive side, but I'm the first to admit there's much, much more stuff to do.
Great. Well, I really want to thank you both for joining me and taking time out of a busy meeting to really discuss and take apart a trial that we don't yet have on paper. So it's a little bit different from what we usually do with the lead, but I think it was a great paper to discuss.
I think it's an important advancement all in all. Really, it is the only way for us to learn what works and what doesn't work is to do these steps. And I think that they have taken a very important step forward with limitations, but still an important step.
Excellent. Well, great.
I think we're all believers in imaging, so you're asking the wrong crowd.
There's no question.
Absolutely.
Yeah, exactly.
Without a doubt. Great. I'm Jason Jacobson from the Digital Education Committee again, and on behalf of Tim and Natalia, we really thank you for your attention, and see you next year at HRS 26.